going to get into our special populations module in this course. So it's going to include your OB, childbirth, newborns, infants and children, and a little bit on geriatrics. So we'll start with chapter 15 on childbirth. And somebody stated something the other day. We talked about special populations and all kind of emergencies. And somebody said we responded to their worst day of their life. Talking about somebody that had a stroke or a major car wreck or something like that. And, you have to agree with that. But I can't imagine, I'm just going to flip through these, you can kind of read them. I can't imagine, if you responded to somebody who was in labor and everything came out okay, and in the end, you would respond to one of their best days of their life. So that's kind of a neat thing when we talk about emergency childbirth. So the two things we'll talk about in here is your obstetrics. We'll talk about normal delivery and then abnormal delivery and newborn care. A little bit on gynecology. So gynecology is a non-pregnant female. And really the only thing that we'll discuss in this module, this chapter, is vaginal bleeding without cause. So other than, normal menses or menstruation, a lot of vaginal bleeding, and it could be some other complications associated with pregnancy. We'll look at those. We'll look at special considerations and trauma for the pregnant patient, and then eventually the pediatric and the geriatric patient. So childbirth is normal. Again, in the end, when most deliveries are pretty non-eventful, I know for us it's kind of a big deal, and for the family too, they really expected to deliver the baby in the hospital, and that didn't happen. We call that a precipitous delivery, when they deliver within 3 hours from the first part from the start of labor. So think of your role as more of guiding, catching the baby, and then your two biggest things is to make sure that the infant has an adequate airway and that they're warm. If you can take care of those two factors, everything's going to turn out, for the most part, pretty uneventful. Indicators of an impending birth. So you get there and the woman says, I'm in labor, and you have to make that decision. Are we going to call for a transport, or are we going to deliver right here? And so you have to make that decision based on these things. Frequency of the contractions, crowning. So how are you going to see crowning? Crowning is the actual impression of the baby's head. Hopefully the baby's coming head first at the vaginal opening. So a rule with somebody that's in labor is you remove everything from the waist down. You have to be able to see. Protect their privacy and their modesty as much as you can, but you have to be able to see. And then listen to the mom. If she says, I feel like I'm going to have this baby, I feel like I'm going to have a bowel movement, well, she's not. It's the baby that she's feeling. Or I feel the need to push. Listen to that, because that's an indicator that she's going to deliver very early on. A little review on anatomy and physiology of the female reproductive system. There's ovaries in the lower quadrants, right and left, that produce eggs. So every 28 days, more or less, each ovum releases an egg. Each ovary releases an ovum or an egg, and it travels through the fallopian tubes toward the uterus. If it's met by spermatozoa in the fallopian tubes, then it becomes fertilized, and then hopefully that ovum will continue on to the uterus, where it attaches to the uterine wall. The uterine wall then is rich in blood. It's a great environment to be able to provide nutrients to that zygote, the developing embryo, in the first little bit until it develops its own placenta. So eventually it's going to be wrapped and encased in amniotic sac, and in that amniotic sac is going to be amniotic fluid. So when somebody talks about the bag of waters breaking, that's what they're talking about, is that amniotic sac breaking, hopefully before delivery. And then the external opening for the birth canal is the vagina. And the cervix, right there at the baby's head, kind of, you can see where it's almost touching, closed off, that cervix will begin to dilate and thin. And then that baby becomes engaged. And then when the baby enters the vaginal opening, then that's where you'll see the crowning. We divide labor into 3 stages. So the first stage is from the first contraction until full dilation. And usually in this, they start to have contractions. The closer it gets to the actual birth of the baby, the shorter time between the contractions. Usually that amniotic sac, that bag of waters, will break. A little bit of bloody show. There's a mucus plug that will come out, sometimes so much earlier. And so that's the first stage of labor. Second stage of labor is from full dilation to expulsion of the baby. So this is where you're going to see the baby's head crowning during contractions. And if you see this, then you have to know there's no time for transport. You're going to do a home delivery, ambulance delivery, field delivery, something. That baby's not going to wait. Then after the baby's born, that placenta, or we call the afterbirth, will be delivered. So the mother will continue to have much milder contractions until that's expelled. You don't pull on that or do anything to hasten it coming. It'll just come out on its own. So the biggest thing you have to think about is, are we going to transport, taking the chance of having to deliver en route, or are you going to stay on scene and deliver? So usually the first pregnancy, the woman's in labor much longer than she is, say, like the 5th or 6th. If she's already spotting, if the bag of waters is broken, that's going to hasten delivery so much faster. So how frequent are the contractions? We measure these from start to start, from the start of one to the start of the next. So if they're less than 2 minutes, then that usually indicates you got delivery pretty quick. Listen to what she says. If the baby's head is in that birth canal, it's going to press against the rectum, and the mother will say, I feel like I have to go to the bathroom. Well, don't let her, because she doesn't need to poop. She needs to deliver a baby. And that's that pressure, that sensation that she's feeling. You don't want her to deliver the baby in the toilet. Now, that's not to say that the mom may not pee or poop also, which you have to keep it a very clean environment for the baby. So it's a little bit of a challenge to separate all the fluids and everything that's coming out of the mom. Look for crowning. That's a telltale sign. So remember, male, female, it doesn't matter. You have to make sure that everything from the waist down is off. Is transportation available? You may have bad weather, you may have a flood, you may have a natural disaster or something that's going to prevent transportation, so that's going to be a factor in there too. Distance to the hospital, and if an ambulance is readily available. And this is the time of contraction, so from the start of one to the start of the other, and then that little wave-like, the taller it is, the more intense it is. Some women will complain of 20 of 10 pain during the most intense moment of contractions, and others will have very light sensation with that. So if you see that head crowning, prepare for delivery. Don't risk transporting anything else. As you prepare to assist, keep 2 things in mind. Calm the mom. You don't have to admit to her that, hey, this is my first field delivery ever. And calm yourself. You're there to help. This is a very natural process. 100 years ago, people didn't go to the hospital to deliver babies. So you're not going to have sterile conditions necessarily, but you want to be as clean as possible. So wash your hands, put your gloves on, have plenty of clean towels, sheets, something. And if you're using things out of the ambulance or out of your kit, blankets as much as you can, or sheets, or trauma dressings and gauze pads and things like that. Make sure that the patient's on a firm surface. If they're in bed, in the middle of the bed, when they kind of sit up a little bit because they have to, they don't want to lay flat, that baby is like a bowling ball, like a 12-pound bowling ball between the baby and the fluids and everything else. And that will press posteriorly and cut off the vena cava, which brings blood back to the heart. And it'll actually make the patient feel shocky. So we call that supine, because of the position, hypotensive syndrome. So you want them sitting up a little bit. With those hips, we'll dig into something soft, and then all the fluid, because they're going to lose about 500 milliliters of fluid, and that's all going to sit there right where they're at. So elevate those hips, get them on a firm surface. The stretcher's good. The floor is not bad, as long as somebody can help her sit up a little bit. Knees bent, and feet flat on that surface below. So she's going to expel both blood and body fluids. So you want to think about your own body substance isolation. Sterile gloves, maybe think about double gloving. That way when you're completely contaminated, you can peel those off and have a fairly clean pair of gloves underneath. There will be splash. There will be splatter. So think about wearing face and eye protection. Now, most women who deliver outside of the hospital just have some situation, weather or transportation or whatever, where they didn't make it. But some of them may be high on drugs, where they don't even know they're in labor. They don't feel those sensation until the baby's almost there. So really think about protecting yourself from any kind of bodily fluids. In the OB kit, and it's a good idea to have these in training so you can actually open them up and see what they have. Usually they have 2 clamps, a scalpel, they'll have some personal protective equipment, a bulb syringe to suction out the baby, and I love the little silver swaddlers to keep the baby warm. So once those clamps are all the way shut, they stay shut, so don't play around with them. Shut them, because then that's it. Sanitary pad, you get 1 of them for all the copious bleeding that she's going to do. Towel or a blanket, and again, I like that silver swaddler, and then that bulb syringe. There's some other things that you may need in your response kit or in the ambulance. If you don't have a delivery kit, then look for things that you can substitute with. You can use ties, like clean shoelaces as a tie, and then something to cut the cord in between. So think about it. You have 2 lives to be considered in this situation, the life of the mother and the life of the newborn. So don't neglect the mom to take care of the baby. In fact, if you do transport, you always want to have 2 people in the back of the ambulance if at all possible. You're going to be outnumbered. If it's just you with the mom and the baby and one of them needs attention, a little bit of oxygen or whatever, then you're going to completely ignore the other one. When you're assisting with delivery, the infant's head usually emerges pretty slow, and they'll kind of come out with a cone head shape because they've been in that birth canal for a while. The vaginal tissue often will tear. Usual babies' heads are like 14 centimeters, and the cervix will dilate to like 10. And so you're going to have some tearing between the vaginal opening and the rectal opening, or the anus. So as the head emerges, just support the infant's head. So don't push, don't pull. You're just supporting. You don't want an explosive delivery. The largest part of the baby coming out is going to be the head. Once the head's out, then the baby rotates a little bit, because the vaginal opening is kind of oval with a taller part in the middle. It goes up and down vertically, opening like that, like an oval. So the baby's shoulders will rotate so that they can squeeze through that oval a little bit better. So head first, and then it starts to turn. While it's turning, you can suction we call it suctioning at the perineum. You can use your bulb syringe to suction there, or you can just wait till the baby completely exits, which is okay. So the baby's going to be very wet and very slippery. Don't drop them. Make sure you have something below that's going to support that baby should you slip. And catch the baby in some kind of blanket so you can start drying him off right away. And here's a diagram. Here's some pictures, top left, of the head coming out face down. And then the baby turns so that shoulders can be delivered. And all you're doing is guiding. You're not pulling. You're not pushing. As the head comes out, look for the cord around the neck. Then you would want to tell the mom to stop pushing, breathe. And that's a very hard thing to tell them to do, to stop pushing. If the baby delivers and the amniotic sac has not been broken, then you just tear it. Just pull it apart with your fingers, push it away from the head and the mouth. And it's going to be a gush of fairly clear fluid. It's got a nice little scent to it. Although it's clear, it smells a bit. I can't say that it's an ugly smell or foul. It's just really different. And this is where you would check for that umbilical cord around the neck. If it's there because the baby has cord entanglement, then slip it over the head. Don't pull on it. Just trying to guide it. Remember, it helps you that they're slippery, right? Now care for the newborn. When the baby's all the way out, we want to clear their airway and keep them warm. So we're going to use our bulb syringe. We're going to squeeze it in, then insert it into the mouth, and then let go, and it'll suction up some of that fluid that's in there. So think about this. The baby's been living 9 months in a space where they got oxygen through their umbilical cord. Their lungs are full of amniotic fluid. In fact, their digestive system is full of amniotic fluid. And so we want to clear that out. We want to suction the mouth first and then the nose. Reason being is because they're obligate nose breathers. Babies cannot breathe through their nose. Through their mouth. The only time they can breathe through their mouth is when they're crying. So we call them obligate nose breathers. If I suction out the nose first and they start breathing, then they suck in some stuff that's in the mouth. So think of it this way: one mouth, two nares, 1, 2, in that order. And then to keep the baby warm, you can place it up on the mother's abdomen. Skin to skin is really good to keep them warm. Just sometimes common sense. If you're in a house and it's summertime, you think, oh, it's nice and warm, this will be great. Well, the thermostat set at 72. That's not great. So even in the back of the ambulance, you have to think about maybe turning on the heater for the comfort of the baby rather than your comfort. So it shows squeezing the syringe, inserting it into the mouth, and then letting it go, and that sucks out that amniotic fluid. Assess the baby. If the baby's not breathing, then you want to stimulate them. So suction again. You can rub the infant's back or flick the soles of their feet. We don't hang them up by their feet and smack them in the butt. And you just want to irritate them so they start breathing. Breathing clears that amniotic fluid out of the alveoli, out of the lungs, so that they can breathe better. Remember, the two most important things you need to do is keep the airway open and keep that baby warm. Most people lose about 70% of their body heat from the head, so when we say keep them warm, make sure that you cover the head also. When the umbilical cord stops pulsating, then you want to clamp it about 4 inches from the baby with 2 umbilical cord clamps. Or you can tie it off with like I said, things that you can get, shoelaces or gauze or something like that. Fairly clean, not your dirty shoelace. Now, your book doesn't talk about cutting the cord. It just says clamping the cord. If you have an OB kit and you're comfortable doing it, place the first clamp 4 inches from the baby. It's about 4 fingers, so your hand away, and then the next clamp maybe an inch or 2 away, and then cut in between. We clamp off both of them, mainly so we don't have a bloody mess, but also that the baby doesn't bleed to death. Note the time of delivery. 3 things that nobody ever tells you in class to learn. What time was the delivery? What's the gender of the baby? Some people forget to look. They're so busy looking to see if they're good color and they're not blue and all this stuff, they forget to look. And then if you're transporting, say that somebody's in labor and you deemed it safe, hey, let's transport them, and you're headed to the hospital, and then they're like, wow, I really feel the need to push, and you look and the baby's crowning, and you have your driver pull over, have them know what county they're in. Whatever county they're in, that's where the birth certificate will be issued from. If there are multiple birth, then prepare for the second delivery. Usually the mom will know that ahead of time. And usually with like twins, that's probably like hopefully your worst case scenario, not triplets or quadruplets or something like that. The babies are going to be smaller. So kind of expect for them not to be as big, not to have as much body fat. That third stage of labor, that delivery of the placenta, usually takes place on its own. If you have clamped and cut, if that's in your protocols that you can do that, you'll have a bag in that amniotic kit to put the placenta in. Don't just throw it in the trash. The physician at the other end is going to want to look through it and make sure that it's complete, that the mother didn't have a retained placenta or anything. If you're not, if you don't have protocols to cut it, then you want to keep it at the same level of the baby and just put it in the bag, put a little twist tie on it, and you're in good shape. The mother's bleeding usually stops after that placenta is delivered. That's why just that one sanitary napkin is pretty much what you'll need. She'll saturate that pretty quick, but that's usually all that comes in there. So if not, if she continues to bleed, massage the fundus. So right above the pubic bone, you want to take just kind of one hand, the flat part of your hand, and just in a circular motion, massage the uterus. Just nice, like you're kneading the dough, because she's usually pretty soft, especially after the delivery of the baby. Should take about 3 to 5 minutes for the bleeding to stop. And then keep mom and the baby both warm. You'll be surprised. As excited as mom is, she's very tired, and she'll usually crash out at this point. So if that's the case, don't try to support the baby up on her abdomen and transport like that. You're going to want to secure the baby better. Look for excessive bleeding with the mom. Continue to massage the uterus if it's not firm or if that bleeding continues. If the baby requires resuscitation, so hopefully you get them crying really loud. They're born blue. Most babies are born cyanotic. They live at about like 30% oxygen when they're in the uterus. So we want to get them crying on their own, and they'll start pinking up or whatever normal color that they should be within about 5 to 10 minutes. But say that they're not breathing on their own, then we want to provide positive pressure ventilations. These ventilations are also going to improve the heart rate. Your goal for heart rate is a rate of at least 100. And if that heart rate remains slow, like 60, and they're still not breathing very well, then you can start CPR. We'll pause here, just kind of make it half of a lesson. We'll talk about some complications. Remember, most labor and delivery are normal. Oftentimes you'll get there after the baby's even been delivered.